Thank you very much, and thank you for the opportunity to present this topic on CAR T cell in relapsed brain tumors. And thank you also from Angela Mastromuzzi, the Chief of Neuro-Oncology Unit at Bambino Gesù Children's Hospital in Rome, who could be here today. Chimeric antigen receptor are artificial fusion molecules that are genetically manufactured and that can reprogram the specificity of the peripheral blood polyclonal T cell against a selected cell surface target. CAR T are composed by receptors that combine the specific binding domain from a tumor targeting antibody with the T cell intracellular signaling domain to allow specifically target antibody redirected T cell activation. There are different CAR T cell constructs today. Now, the most used in clinical practice is the third generation CAR T, and the difference between the second and third generation CAR T consists in co-expression of two costimulatory domains, CD28 and 41BB, that confer higher expansion and persistence to CAR T cells. But today are developed also more refined constructs, such as the first generation one, that also includes the expression of stimulatory cytokines that will be very important to expand more CAR T cells. And the CAR T cell approach includes different phases. First of all, the collection of peripheral lymphocytes from the blood of the patient. The second phase involves the T cell activation and transduction in lab. After the viral transduction, the cells are put in a culture to expand the number of CAR T cells. And when the product is ready, we can start with lymphodepleting chemotherapy, because we know now that patients with lymphodepletion regimen have a potent efficacy and expansion of CAR T cells in respect of patients that didn't receive chemotherapy. After 3 days of chemotherapy, we can infuse in the peripheral blood of the patient the T cell, but we know that in the case of brain tumor, we can choose also other routes of infusion, such as intraventricular, intrathecal, or intratumoral routes. Chimeric antigen receptor cell therapy has provided very, very encouraging results in relapsed and refractory acute B-cell leukemia and high-grade B-cell non-Hodgkin lymphoma. These results have opened an interest also in solid tumor, but with poor results today. The main limitation of CAR T cell in solid tumors include the heterogeneous expression of target antigen, the difficult trafficking and penetration of CAR T cell into the tumor, and the poor expansion and persistence of CAR T cell due to the immunosuppressive and hypoxic tumor microenvironment. All these conditions are even more represented in brain tumors. There are some clinical studies today on the use of CAR T cell in solid tumor, and as you can see in the slide, mostly in brain tumor and in neuroblastoma. I show you our new data recently published in New England Journal of Medicine of our study conduct here, Bambino Gesù Children's Hospital, on 27 patients with relapsed or refractory high-risk neuroblastoma treated with GD2 CAR T-cell. As you can see on the second part of, on the C part of the plot, the overall survival for this patient is about 60% when treated with recommended doses of 10 million of CAR T-cell per kilogram. And regarding the clinical response of the patient, we found a complete response in 33% of the entire population. In the 30% of patients, we detected a partial response, in 20% of stable disease, and in the last 20% of progressive disease. Globally, we detected a detection rate, overall response rate of 63%. It's a very, these results are very strong because you know that neuroblastoma, high-risk neuroblastoma today had a survival very poor, less than 50% described. And the data that we found and that we published in New England are very encouraging for the use of CAR T-cell in this category of the patient. Moreover, we found that the treatment was more effective in patients with a low burden of disease. But there are a lot of consideration to do for brain tumor. We know that low PD-1 expression and low cytotoxic CD8 tumor-infiltrating lymphocytes confer an immune-privileged tissue microenvironment in brain tumors. Furthermore, we know that brain tumors are often defined as cold tumors. Why? Because they carry few mutations, and this is also given a poorer response to immunotherapy. And so much progress has been described in the treatment of brain tumors in recent years with good results on overall survival. Unfortunately, for some of them, for example, for high-grade glioma, diffuse midline glioma, the clinical outcome is still very poor and the prognosis severe. We can find a possible solution for this patient. CAR T-cell could be the answer. But we have to also consider the limits to this kind of treatment in brain tumors. We know that CAR T-cell, they have to cross the blood-brain barrier, they have to persist on tumor tissue and expand on the microenvironmental landscape. But now the blood-brain barrier, the rule of blood-brain barrier is changed on respect of last year, because the brain is not considered a sanctuary. It was, there are a lot of studies highlighting an existing afferent mechanism for CNS participation in regional lymphatic traffic. Identification of the glial lymphatic pathway offered a mechanism for fluids and solute clearance from the brain, linking the parenchyma and interstitium to the CSF. Newer paradigm documented the T-cell entry and immunosurveillance within the brain, disproving the notion that blood-brain barrier acts as a hermetic seal to immune cell entry. In response to inflammatory stimuli, including those derived from tumors, brain stromal cells produce a high level of classic and other inflammatory mediators in a such complex mechanism as you can see in the picture on the right side. But by what mechanism can CAR T-cell reach the tumor? There are three possible ways. The first one, via the post-capillary venules into the perivascular space. The second one, by extravasation through the porous plexus. And the third one, through superficial leptomeningeal vessels in the subarachnoid spaces. As you can see, the CAR T cell can recognize the specific antigen on the surface of the tumor. Release after this, the T cell will be activated and release different type of cytokine, inflammatory cytokine, with the recruitment of dendritic cell and APC that will be put in the lymphatic traffic by the lymph node, and that by the blood they can return to the tumor for to kill the cell. Finally, we have two ways of killing the tumoral cell: direct killing by the CAR T cell and by the recruitment of the T cell compartment of the patient. But what kind of antigen we can target with CAR T cell? There are different types of antigen expressed on the surface of the tumoral cell. For example, we found HER2 or interleukin-13 receptor alpha 2, dysganglioside GD2, EGFR, and so on. It's very difficult to find the best one, because ideally the best target will be the one most expressed in the tumor cell, but at the same time not expressed in the healthy tissue, because we have to consider also the toxicity. For brain tumor, in the literature, one of the best target considered is GD2. And in this slide, I show you the results of work of our group on GD2 expression in pediatric high-grade glioma. As you can see, GD2 is widely expressed in pediatric type diffuse high-grade glioma patient tissue samples and is heterogeneous in terms of intensity and of localization. In vitro, in patient-derived cell line, GD2 expression appears more restricted to H3K27 mutated DMG. In this picture, you can see the response in a model mouse to GD2 CAR T cell. As you can see, after 21 days after the infusion, the tumor, the illumination, it disappears. This data support the potentially efficacy of CAR T cell in DMG, in high-grade and in high-grade glioma with high expression of GD2. And the same data were supported by the autoptic specimen analysis. But we search for GD2 expression also in other kind of tumor, brain tumor. Medulloblastoma is one of the most common brain tumor in children. And we know that today are defined 4 subgroups with Tony-Kedjo, group 3 and 4, with different survival. And the treatment for medulloblastoma includes surgery, radiotherapy, and chemotherapy. But for relapsed one, it's difficult to find a definitive cure for these patients. GD2 expression in medulloblastoma is heterogeneous but high in an elevated number of cases. And also in this case, we found that the mouse model responds very well to GD2 against the GD2 CAR T cell against the tumor. But we detected also other kind of antigen expressed in medulloblastoma, such as EPA2, HER2, and interleukin-13 receptor in medulloblastoma, but also in other kind of brain tumors, such as ependymoma. And in this case, we confirmed the efficacy of CAR T cell treatment against this antigen, providing a rationale for clinical trial of this approach also in humans. Our group explore also the possibility of a combined treatment with GD2 CAR T cell and the EGF-1R receptor as a potent therapeutic strategy for DMG H3K27 mutant tumors. And we found a potent anti-tumor activity in this mouse model. And then we can speculate that double therapy with GD2 CAR T cell may be more effective than the CAR T cell alone. The preclinical results encourage the scientific world to explore the efficacy and the safety of CAR T cell in phase 1 trial in brain tumor. Here, the first published case, this is an adult with a high-grade glioma, in which serial intracavitary doses of CAR T cell were infused. And as you can see in the MRI images, after 6 cycles, the reduction of the tumor was significant in respect of the status before the infusion of CAR T cell. In this case, the antigen selected was interleukin-13 BB chain chimeric antigen receptor. And the Stanford group published 2 years ago the first 4 patients treated in the phase 1 trial with the GD2 CAR T cell for DMG. And they described 3 cases of DMG pontine localized and 1 spinal DMG. Clinical and radiological benefits were presented in this paper. Also, the type of toxicity presented by the patient and the detailed design of the study. After the CAR T manufacturing, all the patients received lymphodepleting regimen, and at day 0, CAR T cells were infused intravenously on peripheric line. And after 28 days, during which the patients were monitored for toxicity, optional intracavitary infusion of CAR T cells were permitted. And the authors described a radiological response in all cases and also clinical improvement. Now I will present you our recently open phase 1 trial of anti-GD2 chimeric antigen receptor in pediatric and young adult patients with relapsed refractory CNS tumor that the study is now open in our center. It's a phase 1 trial. There are 3 arms of enrollment. The first one for medulloblastoma and other embryonal tumor. The second one for hemispheric high-grade glioma, and the third one for thalamic high-grade glioma and diffuse midline glioma and other rare CNS histology. We choose this design for the trial to check the toxicity of the patient, because we know that midline lesions are at risk of hydrocephalus and intracranial hypertension during the pseudo-progression of the lesion. And we choose to start with little localization of medulloblastoma and other embryonal tumor in reason of autism. Our trial design includes escalation, de-escalation design. The first 3 patients will be treated with 1 million of CAR T cells per kilogram, and if DLT, dose level toxicity, were not recorded, we can increase the dose at 3 million, and we can continue with the subsequent arm, the arm B in this case. All patients will receive lymphodepletion, and CAR T cell will be administered intravenously. What kind of toxicity we expect? First of all, CRS, cytokine release syndrome, neurotoxicity, and TIAN. I will explain step by step. Cytokine release syndrome is an important inflammatory syndrome that includes fever in about all cases, capillary leak syndrome, and diarrhea, cutaneous rash, and rarely, but it's possible to have an involvement of organ injury of kidney, of liver, and it's very, very recommended to know the possible complication of cytokine release syndrome to better manage the patient. In this slide, you can see that there are 4 grades of gravity severity of cytokine release syndrome, and for each grade there's some indication for management. The same thing happens for immune effector cell-associated neurotoxicity syndrome. It's a neurological syndrome with different kinds of symptoms, lethargy, irritability, and in the mild case, headache, but in some case we can have seizure or coma. It's very, very important to closely monitor the patient and to know the possible symptoms of ICANS, because we have to start, for example, steroids or other anti-inflammatory treatment to help the patient and to manage these symptoms. But CAR T cell therapies direct at the central nervous system could induce additional neurological damage as a side effect of inflammation arising in the context of the tumor direct therapy. CAR T cell therapy induces inflammation causing tumor and peritumoral edema. This localized edema alone can induce neurological symptoms. However, if edema leads to a mass effect and compromise blood or CSF circulation, ischemia or increase intracranial pressure can be life-threatening for the patient. We have 2 types of TIAN. The first one represented by neurological symptoms and signs due to mechanical factors such as elevated intracranial pressure with high risk of herniation, and in this case it's very important, the neurosurgical management. For type 2, there is a local neuronal dysfunction and typically manifests as transient worsening of the symptoms, neurological symptoms of the patient, and in this case, conservative management with steroids, for example, is recommended. Also for TIAN, recently were published these purpose of grading with some indication for management of the patient. But we are at the beginning of the experience with CAR T-cell in brain tumor, and there are a lot of considerations I think that we have to do in the future. Brain tumor are the most common solid tumor in childhood, with a poor 5-year overall survival in high-grade glioma and diffuse midline glioma. Challenge of CAR T in brain tumor involve antigen selection, immunosuppressive microenvironment, and persistence of CAR T cell in the hard trauma microenvironment of this kind of tumor. GD2 is widely expressed in pediatric diffuse high-grade glioma and other kinds of brain tumor, and is a good candidate for CAR T as a target antigen in brain tumors. Alternative strategies to direct deliver CAR T cell in the CSF include spinal intrathecal infusion, intraventricular infusion, intratumoral injection, and destruction of blood-brain barrier bifocal ultrasound. But now we know that the brain is not a sanctuary, and also with peripheral intravenous infusion, we can reach the tumor. And we have the confirmation of this also with the data that we have from the CSF analysis in patients treated with neuroblastoma in our personal experience. And potent anti-therapeutic strategy for DMG mutants will be in the future the dual combination of CAR T cell with EGF-1R inhibitor. And pay attention to the toxicity. We have to know the risk for this patient during treatment with CAR T cell, and we have to know how to manage the toxicity. Thank you very much. Thank you for the invitation to your Congress, and thank you to Angela Mastronuzzi, Chief of Neurosurgery Unit of Oncohematology Department in Bambino Gesù Children's Hospital, for this opportunity.
Thank you very much, Dr. De Balto, for your excellent talk and for giving us an update about the CAR T cells for the therapy of relapsed medulloblastoma or brain tumors. Questions? Okay, I have a few questions. What do you think? I mean, is the most important thing, is the most important barrier to CAR T cells is the heterogeneity of the in the expression of antigens, and if yes, can we overcome this problem by combining 2 or 3 CAR receptor constructing, so that the target are 3 and not 1 antigen? That is the first question. And the second question: if you strongly believe that the microenvironment of the tumor that is highly immunosuppressed, is the problem, then can we use the fourth generation CAR constructs by incorporating in the CAR construct the IL-8, for example, gene to help this suppression, or another combination with perhaps checkpoint inhibitors or other drugs in combination with CAR T cells?
Yes, I think that for solid tumor, not only for brain tumor, but the issue of the heterogeneity of the antigen is very important. And now there are also preclinical study on the use of CAR T cells against not only one target, but multiple targets.
3.
Because the tumor cell is very, very intelligent, and we know that it can overexpress the antigen during time. And it's important for to reach the objective of to destroy the tumor, to consider multiple target antigens. But now there is not so much experience in clinical, not in clinical patients.
But there are some protocols, I think, clinical trials, I mean, ongoing. I know one clinical trial combining three targets and is, I think, from Seattle. It's a group. But
in adult patients.
Yeah, but of course it's very early. There are no results.
Yes. No.
And what about combining other like checkpoint inhibitors with CAR cells? Or
yes.
And how is the experience there?
Yes, there are some experience in adult patients, also combining inhibitors such as PD-1 and PD-L1.
Yeah.
Yes, and also to use fourth generation CAR T cell with the aim to increase the number of pro-inflammatory cytokines, to have the CAR T to expand and to help the recruitment
to avoid the exhaustion.
Yes.
Yeah.
The exhaustion, and to involve also the immune system of the patient to fight the tumor.
And the last question: what do you think? I mean, can we wait in the next 5 years that we have such therapy, immune therapy for brain tumors, or do we need more time?
In our experience for our clinical trial, do you mean?
Yeah.
We enrolled the first patient.
4.
Now, I think that by the end of the year, we can have just an idea on the toxicity, sure. But for the conclusion of the trial, we planned 2 years to give you also data on the efficacy.
Okay. Thank you very much. Thank you very much.
Thank you for the invitation.
There is one more question from Dr. Papadakis.
Thank you for the excellent talk. It was not very clear to me. For the IV infusions, you use lymphodepletion, correct?
Yes.
Okay, but for the intraventricular and the intralesional, you do not, correct?
Not in our trial. The infusion is intravenously.
Yes, but wouldn't it be for brain tumors? a strategy to do the intraventricular to avoid lymphodepletion, or you just try to copy the neuroblastoma experience to the brain tumors? What's the thinking behind your decision? I'm trying to understand.
There's not a consensus on this, but lymphodepletion regimen now is used also for in local infusion, intrathecal or intratumoral infusion.
Thank you.
I mean the reason was that at that time, that was 3 years before, or 4 years, the local administration, because we didn't know that the CAR cells can reach the tumor.
Yeah, but you can avoid lymphodepletion.
Although we had the experience that CAR T cells could be identified in cerebrospinal fluid.
Yeah, they can be effective for CNS leukemia. So.
Yeah. Okay.
Thank you.
Thank you very much.
Okay, thank you. Bye.
No.
I just wanted to say a big thank to Giada for her participation and for accepting to talk, to give us this very interesting talk about the CAR T cells. Thank you, Giada.
Thank you too, Vita. Thank you for the invitation.